Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. So, as we know, we are discussing about different types of congenital cardiac problems, and we have already seen how they are classified. Now, one of the classification is cyanotic heart disease, and one of the condition which comes under the acyanotic heart disease. Acyanotic heart disease. One of the condition is acyanotic heart disease, and one of the disease which comes under the acyanotic heart disease is ASD. This is this is ventricular. This is a defect at the atrial level. So one of them is a ASD. So let us see about the different types of ASD and how the clinical manifestation will be there. ASD has been considered as one of the congenital problems most of the time remain asymptomatic. Even throughout the life also it remains asymptomatic many times. Now there are many types of ASDs. One is ostium secundum type, which is 75%. Another one is ostium primum type. Another one is sinus venosus, which is about 10%, and unroofed coronary sinus. So these are all different types of ASDs. ASD with the normal JVP. Now ASD means it is related to atria. Atria is connected with the jugular veins, okay, brachiocephalic vein, and also it has got direct relationship with the JVP. So ASD with the normal JVP and systolic thrill in pulmonary areas indicate of the larger shunt. Suppose the shunt is bigger, then we can assume that so there will be more amount of the blood which is coming to the right atrium, and this right atrium and left atrium, and there is intermingling of the blood. So total the atrium act as a pool of the blood, okay, and more collection of the blood will be there, and as a result JBP will mostly going to rise. If that is happening, that suggests that a larger shunt. So JBP is the main indicator here. JBP is there with the ASD, then it's a larger shunt, and JBP is not there with the ASD, then it may be a smaller shunt. Now there will be a wide split of S2. S2 is definitely wide split. A murmur is very soft, so most of the time it is left undiagnosed. The hallmark of is the wide split second sound with a soft murmur in the pulmonary area. Suppose in the pulmonary area there is a wide split second heart sound with a soft murmur in the pulmonary area. So that is one of the characteristic feature. In the ECG actually ASD may show some sinus rhythm and also prolonged PR interval. Now let us discuss about the VSDs. ASD is over. Now let us discuss about VSD. So VSD, the problem is that a ventricular area. So this is about 20% of the cases we will have VSD. So VSD may be there at the ventricular area, or VSD may be there with the aortic regurgitation, and VSD may be there with the left ventricle to right atrial shunts. There is a VSD with the left to right shunt or right to left shunt, both can exist. Initially to start with it is left to right shunt. Now first we will discuss about left to right shunt. Left to right shunt can occur at the aorta pulmonary level, about 4.7% cases. The most common examples like a patent ductus arteriosus and aorta pulmonary window. Aorta pulmonary window. Similarly, aortic root to right side of the heart. Another one shunt can exist at aortic root to right side of the heart. So this can be possible in case of coronary artery fistulas or RSOV, rupture of the valsalva, and then anomalous origin of the left coronary artery from the pulmonary artery, and VSDs, etc. Now small VSD with the normal atrial flow with a systolic thrill of 4/6 and a long systolic murmur, asymptomatic murmur may be closed spontaneously. Now often the question will be asked, what are the possibilities that VSD can spontaneously close in a growing child? So this is a criteria. Asymptomatic murmur is there, 4/6 long systolic murmur is there, normal aortic the functioning is there, and systolic thrill is 4/6. So that may close spontaneously at times. Okay. Or another type of the VSD is small VSD, another is the moderate VSD and large VSD. Small VSD you have seen, which can spontaneously close. Moderate and large VSD and Gerbaud defect. Okay, so that's the left ventricle to right atrium shunt. This is another way, Gerbaud defect. So these are all very difficult to close. It may need surgical intervention. Now, what is actually the management? The spontaneous closure of the VSD, don't commit to any patient. Don't commit to any patient regarding the spontaneous closure of the VSD, because it depends many times. Because this leads to increased incidence of shunt reversal. Most of the time when you neglect the shunt reversal, left to right shunt become maybe a right to left shunt and become more complicated. So it is very important to have a proper follow up and proper checking periodically. Then closure is quite common in any muscular defect of the heart in 80% of the cases, followed by the perimembranous defects. Now you have to see whether it's a muscular defect or some other defects or a perimembranous defect. So closure is possible if only muscular defect is there. Muscles as grow, the closure may occur. Okay, if there is some problem with the valves itself, then it's maybe difficult. So 80% of the cases. Closure is rare in Quillet VSD or inlet VSD and in Swiss cheese VSDs. 25% will close by 1 year usually, if it is closable. 25% will close by 1 year, 45% of the small VSD may close by 3 years, and 90% may close before the 8 years of the age. Only 7% of the cases with a moderate large VSD and CCF in the early life will close later. That means in the early part of the life, if more symptoms are there, chance of closure is very less. Only 7% cases with a moderate large VSD and presence of the CCF may close in the future life. This is about the different types of acyanotic heart disease. Now talking about the cyanotic heart disorders. The cyanotic heart disorders that we will discuss in the next class. Thank you very much.